Scleroderma, on the other hand, is a different disease. This is also not an uncommon disease, but it presents with certain very interesting manifestations. So let's look at this. A 36-year-old woman comes to see you because her skin feels tight. She also reports painful discolored fingertips with exposure to cold. The physical discloses an elevated blood pressure, shiny, taut skin, thickened skin. The laboratory tests reveal an elevated creatinine. So she feels tight skin, right? She says she has this discolored fingertips, exposure to cold, right? This is Raynaud's. And then you look at the skin yourself, it's shiny, it's thickened. So this is the typical patient with scleroderma. And the problem with her is she's got her creatinine elevated, which means that scleroderma has affected the kidney, which is, as we'll see in a little bit, is a bad sign. So scleroderma is a chronic multi-system disease, and you have clinically thickening of the skin and accumulation of connective tissue, and by involvement of visceral organs, GI, the esophagus, the bowel, the lungs, the kidney are the most important sites. So the way you remember this is, well, the vascular obliteration that these patients get from the Raynaud's in the fingertips, right, is the same one that they get in the organs. Vascular obliteration, right, and inflammation, and then fibrosis. Where? In the fingertips, in the skin, in the lung, in the kidney, in the GI tract. Those are the main areas. Raynaud's phenomenon and skin thickening 100%. For you, for the boards, all these patients have to have Raynaud's phenomenon and they have to have skin thickening. 100%. You cannot make the diagnosis of scleroderma for your tests without these two. And then these patients may get a combination of some other stuff. GI manifestations. For example, these patients have a form of something that looks like achalasia. It's not exactly achalasia because the whole esophagus involved, but it's basically esophageal hypomotility or dysmotility. And then you may get bowel dilatation. They may show you this x-ray of the abdomen with these big loops of bowel, and they say this patient has this, you know, on the x-ray, and she also has Raynaud's, and she also has thick skin. What does she have? She's got scleroderma. So commonly, the GI tract is affected. And then pulmonary, this is the most common cause of death right now, pulmonary fibrosis. These patients have pulmonary involvement, and then they go on to develop pulmonary hypertension and pulmonary fibrosis, and the most common cause of death in patients with scleroderma right now is this pulmonary fibrosis. What used to be the cause of death years ago was what this woman will likely get is scleroderma renal crisis. Scleroderma renal crisis is when scleroderma affects the kidney, these patients get this form of aggressive acute renal failure. It's because the scleroderma has affected the kidney, and along with that, the acute renal failure, it's malignant. They develop malignant hypertension. And most of these patients, once they went into the scleroderma renal crisis, they would die within a short time. Weeks, months, or whatever, maybe, you know, even a year. But they would die because of the renal failure, because of the severe hypertension and so forth. And that was because we couldn't give any medications to basically lower their blood pressure and stop their renal failure. And now we have the angiotensin converting enzyme inhibitors that basically have resolved this issue. So all the patients with scleroderma renal crisis now, or people with hypertension and scleroderma, or renal failure and scleroderma, we put them on an ACE inhibitor and their kidney function stays the same or improves. So that has been resolved. That's why this is not a common cause of morbidity and mortality now because of the use of the ACE inhibitors. It's very treatable. So now we got the pulmonary fibrosis. So beyond that, we have the antibodies, the anti-nuclear antibodies, and it's very simple to remember that these antibodies usually have the SCL. SCL stands for scleroderma, SCL, and then they got a number after that. So we get one of those SCL70, SCL90, one of those antibodies are positive, and it confirms your diagnosis of scleroderma. The clinical picture plus the anti-nuclear antibodies confirms it. There is no treatment for scleroderma. I should be more specific. There is no cure for scleroderma. There's treatment of the symptoms. That's what we do. We try to treat the symptoms. For example, for the skin manifestations, we give D-penicillamine. For the Raynaud's phenomenon, which could be disabling sometimes, especially if the patients live in cold climates. This patient that I was talking about lived in Chicago. She had severe Raynaud's, couldn't go out in the wintertime. We give them calcium channel blockers. They're very effective. And then for the renal crisis, the hypertension, or the renal failure, ACE inhibitors in this case have been life-saving. CREST syndrome is it's a subcategory of scleroderma. It's also called now limited scleroderma. You may not hear the CREST thing. You may hear limited scleroderma. That's the right terminology now. Now, CREST stands for calcinosis. These patients get these coarse calcifications usually over the arms. The R is Raynaud's. The E is esophageal dysmotility. The S is sclerodactyly. And T stands for telangiectasias. And CREST really has skin involvement that usually doesn't extend above the elbow or above the knee. Most people with systemic sclerosis, their whole body is infected, their face is affected. These people usually it's limited right to below the elbow, below the knee, limited scleroderma. Generally, the prognosis is much better because this disease progresses much slower than systemic sclerosis. And these patients, though, here's the question they may ask us. Well, do they get anything, bad? The answer is yes. They commonly get arterial hypertension, but because it progresses slower, the inflammatory process is slower, they don't get pulmonary fibrosis as much as the patients with systemic sclerosis do. So even though they have a lot of pulmonary hypertension, most of these patients, it's status quo. It doesn't get worse. Interstitial lung disease may occur in about 10% of this population, so it's not totally uncommon, but it's rare. And these patients have the anti-centromere antibodies positive, not the SCL antibodies like the 70 and the 90 that we saw with systemic sclerosis. These patients usually have anti-centromere antibodies positive. So this is CREST syndrome, or what you are likely to hear about now called limited scleroderma. That is the right terminology. I want to talk to you a little bit about the Raynaud's phenomenon. Some people have asked me and they get confused a little bit. So let me tell you a little bit about it and what the associations are. So this is a very common thing, right? We see this in about 5% of the population. And this is the pallor, the cyanosis, respond to cold or emotional stimuli. So this is the person that goes outside and all of a sudden, they get pallor in the fingertips and then cyanosis, and then they get the vasoconstriction, and then afterwards, because the vasodilation, they get the blue fingertips after a while, as a response to the vasodilation. It is more commonly seen in women, and the thing I want you to know for the boards, there's a primary versus a secondary. Primary is the 5% of the population that don't have any other disease, and they just have this Raynaud's and nothing else. Secondary is when it is associated with some other systemic disease. The most common one of this secondary part right here, the most common one is the association with scleroderma and limited scleroderma. So, well, how do you know which one is which? And the answer is, you do a good exam, you do some blood work, and make sure that this patient doesn't have any evidence of systemic manifestations, other organs involved. Primary Raynaud's doesn't have any other organ involvement. So, for example, if somebody came to me with Raynaud's, and all of a sudden I find that her creatinine is elevated, or she's got crackles in her lungs, or she's short of breath and there's something going on with her lung, I start to think of this as a secondary Raynaud's, and I start to look for some other systemic process causing the Raynaud's. In the rheumatologist's office, commonly you'll see the rheumatologist take the patient's nails, put a little bit of oil on top, and look at it under a microscope. And this is called the nail fold capillaroscopy. You know, the generalists don't do it well, but the rheumatologists are great at this, and what they're trying to look for is there any evidence of vessel damage, right, at the nails? That's what they're looking for. Do you find any dilated vessels there that would point to a secondary systemic process? So for example, if I do it in normal people, you don't see anything there. You see just the vessels taper off, but these patients that have it as part of systemic sclerosis or some other systemic disease, their nail folds, their capillaries in the nail folds are totally distorted, and you could see that under a microscope when you put a little oil there and you magnify that. So that's the Raynaud's phenomenon in scleroderma.